So I'm excited to kick off our afternoon panel. At this time, I ask our panelists to go ahead and turn on the video if you haven't already. We've invited a variety of esteemed experts from across the country who represent many points of view. We want to discuss payment considerations and financial incentives related to population-based total cost of care models, including how to improve the coordination between primary care and specialty care. PTAC members, you'll have an opportunity to ask our guests follow-up questions as we go. The full biographies of our panelists can be found on the ASPE PTAC website, along with other materials for today's meeting, so I'll briefly introduce our guests and their current organizations. First, we have Dr. Alice Chen, who is Associate Professor of Public Policy at the University of Southern California. Maryellen Guinan is a policy manager joining us from America's Essential Hospitals. Next, we have Kathleen Holt, who is the Associate Director at the Center for Medicare Advocacy. Greg Poulsen joins us from Intermountain Healthcare, where he is the Senior Vice President of Policy. And lastly, we have Katie Wunderlich, the Executive Director of the Maryland Health Services Cost Review Commission. So let's get started. So for our first question, in your experience, what works best to incentivize the kinds of care delivery transformation that impact outcomes, quality, and cost, such as proactive team-based patient-centered care? Can you describe existing models that work well? So Maryellen, I'm going to start with you.
Sure. Thank you so much. And thank you to the PTAC for including us in today's important discussion. For those of you who are not as familiar with America's Essential Hospitals, we are an association and champion for safety net hospitals dedicated to equitable, high-quality care for all, and that includes those who face social and financial barriers to care. Just to kind of give a context for my comments, Essential Hospitals and our members really shoulder a disproportionate share of the nation's uncompensated care. So keeping that in mind, with 3/4 of our patients being uninsured or covered by Medicaid or Medicare. And certainly our members and hospitals largely understand and acknowledge, I think, the potential benefits of value-based care in terms of improved health and reducing the effects and incidence of chronic disease. That's something certainly important for the population served by Essential Hospitals. And of course, lowering overall costs to the healthcare system. I think it was touched upon earlier today as well that we saw additionally, that organizations who are participating in value-based payment models also benefited from the flexibility of those models to adapt care models to their patients' needs and circumstances during the COVID-19 pandemic. And so given the benefits of value-based care to patients, providers, payers, and really society as a whole, it's really critical, and that's why I'm glad we're having the conversation, to have a broad array of stakeholders participate in value-based payment reforms, particularly those who may not have been participating as robustly in the past. That is, providers that serve low-income, medically complex, marginalized, and underrepresented communities. So just in terms of your question, I think there are a few areas in terms of just improving the fact that care is very fragmented right now under fee-for-service in terms of paying services piecemeal. So I would say there's a clear benefit from having a multidisciplinary care team. And the note there, I would say, is the importance that within that team, there's embedded not only the clinical components, but also social workers, community health workers, and others in that care team, so that we really are driving at value from a perspective of not only efficiencies, but also equity. I think there's also a need to obviously identify avoidable spending in terms of the specific types of services that could be reduced, but obviously without harm to the patient. I think the issue and complexity here is in terms of identifying which types of services and the amounts of spending that should be avoided. Inevitably, this will differ in terms of different patients, different conditions, and different providers. And it's also something that undoubtedly will change over time as we have new technologies that come into place and whatnot. So just something to keep in mind there. And then I'll just finally say, I think funding and adequate funding is particularly important in terms of incentivizing certain providers and really driving at value. I know we'll probably get into the kind of specifics of design of models and perhaps upfront funding, but right now I'm more talking in terms of adequate funding for high-value services that have the potential to reduce avoidable spending. For example, non-medical services like transportation to and from outpatient sites for follow-up care, or the screening for social determinants of health and subsequent referral process that's often resource intensive and undertaken a lot of times by those community health workers that are part of the care team, but the reimbursement structures right now are not really adequate or there at all for those components of the care team. And so certainly providing that adequate funding for those services would be critical in terms of incentivizing these models. And I'll stop there and turn it over to the other members.
Great. Thanks, Maryellen. Kathleen?
Thank you, and thank you for including me today. I am Kathleen Holt. I am an attorney and associate director at the Center for Medicare Advocacy. We are a national nonprofit law firm dedicated to helping people get access to Medicare benefits and to maintaining the Medicare program. I would suggest that a provider-supported wellness journey from birth to death could help maintain health as well as grow trust relationships with practitioners, provide a baseline for continuous healthcare oversight, and presumably avoid more costly healthcare interventions later. But without an aging wellness bridge between childhood pediatric checkups and age 65, to which many people don't have access or don't feel the need to access healthcare, many patients now arrive at Medicare age viewing healthcare providers as harbingers of aging diagnoses doom. If patients haven't had continuous meaningful experiences with the healthcare system throughout their lives, instead of deferring necessary healthcare services, costly healthcare must then be addressed by Medicare coverage. Individuals may have also developed an experiential and cultural distance from many years without relating to healthcare providers. To address the lack of treatment and trust disparities, new models should be flexible enough to bring more Medicare-covered healthcare to where and with whom patients' lives are centered, with the exception, of course, for necessary critical care or required higher technology interventions. Patient-centered care involving skilled practitioners and trained aides should also include, with the patient's consent, broader-based, trusted members of a patient's own community, including counselors, social workers, faith leaders, advocates, family, and friends. Whether a patient lives alone, with a family, or in community with others, healthcare providers, including primary care practitioners and specialists, may develop care plans with the patient, but achieving consistent, longer-term care plan success with quality results will require coordination with providers and this broader-based community healthcare implementation team who will assist in and hold each other accountable for attaining quality healthcare.
Thank you, Kathleen. Katie?
Good afternoon, everyone, and thank you very much for having me here today and participating on this roundtable discussion about value-based care arrangements and how we can continue to further their application. My name is Katie Wunderlich. I'm the Executive Director of the Maryland Health Services Cost Review Commission. And I think part of what I'm bringing today to this panel discussion is from a regulator's point of view. So just as way of background, the Health Services Cost Review Commission is a regulatory agency that sets primarily hospital rates, but is also tasked with helping to develop and shape healthcare reform, both delivery reform and payment reform in the state of Maryland. And in the state of Maryland, under our total cost of care model, we're tasked with, at a very global level, looking at population-based budgets and population-based ways to address chronic conditions and utilization. Our physicians, though, are on a fee-for-service structure, and so we have to develop voluntary programs that can bring in the physicians into value-based care arrangements. It's really important and imperative because our physicians can't engage on the national programs that we put together. What is meaningful and useful for physician specialists in Maryland. We have one particular a bundled payment program that really is structured for some Maryland specialists. In addition to selecting episodes for those bundled payments, the providers are also asked to name what kinds of interventions they will deploy to reduce costs in those. And of course, those are interventions that not only control the cost, but also improve the quality of care delivered, the quality of outcomes, health outcomes, and patient outcomes. And so they can be around clinical care redesign and quality improvement, including medication reconciliation, standardized evidence-based protocols that are implemented for discharge planning and follow-up care, elimination of duplicative, potentially avoidable complications or low-value services. Our providers also look at interventions around beneficiary and caregiver engagement, because we know it is so important to engage patients and their families as we are looking to address value and to improve health outcomes. So, for instance, through patient education and shared decision-making, pre-admission and post-discharge, implementing health literacy practices for patients and family and patients and their family. Another broad category is care coordination and care transition, which a few of the panelists have touched on the importance of having interdisciplinary team meetings that address a patient's needs, progress, and situation, assigning a care manager and enhancing the coordination of care as that patient goes across care settings, and then, of course, selecting the highest, most cost-efficient and highest quality of care to deliver care for those patients. And so, from a regulator's point of view, we really do try to structure those programs so that physicians and specialists can enroll and engage in it. To provide the right kind of infrastructure, data infrastructure that they can use to support the goals of that value-based care arrangement. And then also, to the extent possible, align multi-payers. And so if we have a Medicare program, we want to, as best as possible, align with other insurers, programs that other insurers have, so that it can maximize the physician's efforts across their entire patient panel, as opposed to just their Medicare patients, because, we are, of course, looking at trying to improve health across the board. So those are just a couple thoughts I had in terms of data, interventions, and multi-payer alignment.
Great. Thank you, Katie. Alice?
Hi, I'm Alice Chen. As you guys have heard, an associate professor at the University of Southern California, and it's really a pleasure to be part of this panel, so thank you for having me. I'm going to sort of address this question from an academic perspective, and I think it's important to kind of take stock of what we know that has worked, and I'm going to focus first on the largest advanced payment models that we have, which are accountable care organizations. Research has shown that the Medicare Shared Savings Program ACOs have generated on average gross savings about 2 to 3%. And the savings rates are higher among physician-led ACOs than other sort of ACO constructs. Physician-led ACOs have savings of about 3 to 5% per year. And we've also seen savings among programs such as Blue Cross Blue Shield's commercial ACOs generating savings rates of about 3.4%. So it's pretty clear that there are savings that occur from these ACO constructs. As you've heard today already, these savings have been low, especially when you take into account the bonuses that are paid out of these models. But even looking at the net savings, having accounted for those bonuses, some of the early ACO models and other models have continued to generate cost savings. Now, in addition, sort of the other important component here is quality of care, of course, and it appears that quality of care has not changed for the most part, neither gotten better nor gotten worse. There's a few pieces of evidence out there showing that there's some metrics of patient experience that might have improved, but it is an area that, would hope to expect or hope to see bigger changes in terms of quality. There are two other models I want to mention in addition to these ACO models. And the first is the episode-based payments, as Katie touched on in Maryland, their bundled payments. The Medicare Comprehensive Joint Replacement Program is arguably the most successful bundled payment experiment in Medicare, generating on average 3% savings. My own research shows that sort of providers participating in these Medicare Comprehensive Joint Replacement Programs have changed their behavior also for not just their traditional Medicare beneficiaries, but also their Medicare Advantage beneficiaries and their commercially insured beneficiaries. So there's spillovers that are created within the Medicare programs that can be realized to sort of generate even larger savings. And in the commercial space, there have also been significant experiment with episode-based payments, and one study shows sort of a 10% increase in savings across a couple different areas of care. So, while the efficacy of episode-based payments are really limited to certain disease areas, I think they can coexist with a broader population-based like ACO type model. And the last point I just want to touch on somewhat quickly is just capitation. And we know that the literature tells us that sort of Medicare Advantage saves on average 10% in cost relative to traditional Medicare. Capitation obviously has no incentives for improvements in quality, but again, capitated payments can be incorporated into something like an ACO model. So to sort of just summarize, I think the research that we have, or the academic research, shows that we need to continue moving towards a multi-track population payment-based model where providers are delegated financial risk. And by putting sort of risk and accountability to the providers, you're putting them, you're leaving accountability to people who are best positioned to judge what is high value, what is low value, and to be able to configure the delivery system to support higher value care.
Great. Thank you, Alice. Greg?
Yeah, thanks for the opportunity to be with you all. As mentioned, I'm from Intermountain Healthcare. We're a fairly large integrated health system. And I think mostly in the Mountain West. The thing that I guess I should mention is that we're about half prepaid at this point for the care that we provide. So we sort of live in both of those worlds. And I can tell you which one we'd rather live in. Absolutely, it's the prepaid. And we view prepayment or capitation, if you will, as freedom. It's not risk. It's an opportunity to provide better care for people that we're able to serve. So with that in mind, I think that to the topic or to the question at hand, Group prepayment is, we think, by far the most effective and most dramatically, and it has the greatest dramatic ability to improve both quality and cost. Alice mentioned that the results so far are limited, at least in what we're seeing in the current programs. We'd wholeheartedly agree with that. But we think that part of that is that ultimately the incentives need to reach provider organizations. Many times it gets stuck today in payer organizations. In Medicare Advantage, for example, the vast majority of Medicare, when it reaches the provider organizations, is fee-for-service. It is not a population incentive that hangs up, if you will, at the carrier level, the payer level. So when it does reach the provider organizations, we think there's an opportunity for huge improvements. And although there isn't a direct incentive for quality improvement, we think that the indirect incentive to keep people healthier, which is dramatically less expensive to care for, is profound. Historically, exceptional groups have demonstrated that capitated payment can lead to huge improvements, both in cost and quality. Unfortunately, those really successful, at least some of those really successful organizations became part of larger organizations, and both the systems and the culture that made them possible. I'm thinking of places like Healthcare Partners, CareMore, WellMed. Really a lot of the magic that was there was dissipated. And I think that that's unfortunate, because I think if we're willing to go back and look at history, we can find examples where real dramatic improvements were made. I think that in this case, and I think there are going to be questions later on that focus on this more directly, but thinking of primary care as an entity is frequently a mistake, for the simple reason that care today effectively provided is clearly a team sport. We see dramatically different outcomes associated with care when whole teams are involved. All of the folks who spoke prior to me mentioned the importance of engaging in a multidisciplinary approach to care management and care practice. And also the fact that in many instances today, it's becoming ambiguous where one specialty ends and another begins, and technology is making those lines blurrier and blurrier through telehealth and through other capabilities that we'll have. So I think that to my key point, providing accountability requires both culture and systems, and it requires organization to make that happen. And one of the things that I think we're going to see is necessary is increased organization over time, and we'll come back to that later. So thanks for the opportunity to be with y'all.
Great, thank you. So before we move to the next question, I just want to open it up to the committee if you have specific questions related to this topic. Larry?
I have one question for Alice. You made a statement that episode-based programs can coexist inside ACOs. Give me some granularity on that.
Thanks, Larry, for that question. It is a challenging question, I will say, and I think people are struggling with exactly how they coexist. But I think there are certain things that need to be identified. When do episode-based payments work? When do they not? Clearly, they work for certain things, but not all things. And then I think one wants to think about whether or not providers in an ACO have incentives or continued incentives to refer patients to episode-based providers if there's sort of two different tracks of payments, one for the episode and one for the ACO. As we currently have it, ACOs who are also providing an episode-based payments will get their episode-based payment counted into their ACO spending, and the episode-based providers will also benefit from that sort of payment sort of savings that they might reach from the bundled incentives that they have. And so that's one sort of, it's sort of maybe a broad kind of picture of how they might be able to coexist. I think there are just certain things one needs to pay attention to. ACOs should be accountable for managing patients with multiple chronic conditions, and it's a challenging sort of population to take care of. You don't want the episode-based payments to focus specifically on chronic conditions, maybe one or two, that would then take away incentives to coordinate across multiple chronic conditions. So that's all to say, like, there is, I think, a way in which carve-outs can be made for episode-based payments, but there needs to be more thought in thinking about exactly which episode-based payments to include and how one would sort of incorporate the payments across both kind of schemes.
One follow-up on that. Instead of carving out, how about nesting them in?
Larry, absolutely. So I'm also glad that you mentioned that nesting them in is also one definite sort of incentive here. I think the one thing that I would mention here is, you want to make sure that ACOs have an incentive to select or contract with more efficient providers. And the contracts within ACOs themselves guide ACOs or incentivize ACOs to naturally do that already. So, nesting the episode-based payments into the ACO-based payments, I think, fits well within the sort of just guidelines of making sure ACOs continue to seek out more efficient providers.
Jennifer?
Thanks to each of our panelists for being here today. My question is for Katie. Katie, you're leading essentially on behalf of the nation one of the largest pilots around total cost of care and have done so for a long period of time. I'm curious if you could talk a little bit about unintended consequences of this approach and what you all have seen, one, in terms of what those unintended consequences are, and then two, how to mitigate that.
Sure. Thank you for that question. And we have been under our global budget model that we've had in place since 2014. In some parts of our state since 2010 have put hospitals under global budget. So providing those financial incentives to reduce utilization. We do look for unintended consequences. One of the first and foremost ways that we try to make sure that we root out negative unintended consequences is through our quality programs. And so we embed all payer quality programs around readmissions, complications, and patient satisfaction, PBR. And so that's one of the ways that in addition to the financial incentives of finding the most cost-efficient setting to provide care, that does not mean that it is withholding care or restricting care to poor patient outcomes. So that's like the first and foremost way that we look at and protect the patients and the population against negative unintended consequences, is to make sure we have rigorous all-payer quality pay-for-performance programs. And then the second way, the other part of the unintended consequence, I think, is to the extent that an organization, a health system, is able to better manage chronic conditions, to reduce the need for high-cost acute care services by putting things upstream. Those are all very good measures. But to the extent that a hospital is guaranteed a population-based budget and a population-based revenue without having to deliver those services in the inpatient side, they can accrue retained savings, so to speak, or additional healthcare dollars. And what we're going through right now is making sure that those healthcare dollars that are accrued because of lower utilization are deployed in the most effective way to continue to support patient access, to continue to address chronic conditions and improve population health, so that we not only improve the health of the population, but we continue to drive down the cost for the entire delivery system. And so, we've been at this for a while, since 2014, but really not that long when you think about it. So we are still understanding where the pitfalls are, understanding how we can make sure that healthcare resources and healthcare dollars that are provided on a population-based reimbursement system are not only driving down utilization and down some of those cost measures, but are also making sure to maintain or improve quality, both the quality of services and health outcomes for Marylanders.
Ginny?
This is, can you guys hear me? Okay. This is for Gregory. You had mentioned that about half of what you guys do now is prepayment, and spoke about a group prepayment that then translates to getting down to the provider level, and you had advocated for a higher percent or a higher sort of provider level. Can you speak to how you, one, made that transition, but also, you know, when you look at the payment methodology out there, it's retrospective, often a long time after the initial investment is required, or the provider behavior needs to be incented. So how did you manage that? And then if you had to, if you had to speak to policy to govern that, how would you craft policy to govern that payment methodology?
Yeah, thanks. That's a great question. And I should be very, very clear. What I think is essential is that the incentive to the provider organization is there. In fact, reaching to the individual providers is maybe not the same thing. In some organizations, they attempt to do that. In others, they do not. Irrespective of that, I think that the key is to have the culture of the organization transformed so that it focuses on keeping people as healthy as possible for the lowest possible cost. Organizations are good at that. They're good at many things. And what they focus on, what they talk about, the key performance indicators that they track, the goals they set, the year-end discussion of performance, all of those things are incredibly relevant. So contrast two organizations, one of which is prepaid, when all of those KPIs are around how healthy are we keeping people. We're looking at their lives as opposed to their whole lives, as opposed to the specific episodes that are associated with it. And we're looking at the costs associated with that. In a fee-for-service world, those kind of discussions don't tend to have a natural occurrence. Instead, what's talked about is, our revenues up? How many surgeries were we able to do? How many people did we see in our emergency room? And those are all positive things when they occur. In an organization that is focused on prepayment, it's how many did we avoid? How many surgeries were we able to prevent? How many ER visits were we able to avoid because people were able to be seen in primary care settings or on telehealth, or they're maintaining their medications because of appropriate care management, so they never had a crisis. So it's not really, in my view, essential, and in fact, in many cases, it's not even useful to have the providers individually incentivized financially, but rather that the organization and its culture becomes coordinated around that. And I think as we look at the organizations that have been most focused on this in the past and in the present, whether it's Kaiser or Geisinger or an Intermountain, by and large, we don't have incentives that reach the individual, at least not in a very, very direct way. And there are some examples from the late 1980s, early 1990s, where those incentives became perverse. And so we discourage the idea of an individual physician, for example, being incentivized in a way that might encourage them to withhold care. Rather, we think that's the role of the organization. So hopefully that was helpful. Did I cover your question appropriately?
You did.
Thanks.
Thanks. Lauren?
So this is a question for the group overall, and definitely to Greg and Katie as well. As you see the administration's focus on equity and social determinants of health, and nationally as we're starting to understand the importance of community-based organization relationships and other networks to actually achieve the outcomes with the clients that we're serving, how do you see payment shifting? So right now we're looking at incentives going to provider organizations or providers, but what do you see coming as the importance of those equity-focused social determinant of health organizations emerge as key partners in achieving the outcomes?
So So I can take a stab at that. I do think so. In Maryland and under our structure, a lot of the care and the outreach happens from hospitals. So when we put forward initiatives to focus on behavioral health or diabetes or other chronic conditions facing Marylanders that have been longstanding health disparities, We've been trying to work at this for the last 30 years, some of these maternal child health disparities, diabetes, others. But as we're looking at how are we effectively communicating and connecting with the community so that on the ground level we can improve health and improve those disparities. In Maryland, a lot of that goes through the hospitals. And so what we're trying to make sure that as a global budget payment goes to a hospital and as we have special funds available for hospitals for chronic disease management, that there's a requirement and an expectation that they will meaningfully partner with their community-based organizations. We had during COVID, we had a community vaccination program that we were able to free up global budget dollars to connect to do community-based vaccination work. And it really required hospitals to work with their faith-based organizations, with their community centers, with primary care and FQHCs to reach patients on the ground. And that really is the way that I think we can, on a long-lasting basis, affect chronic disease management and look connecting with patients on a granular and on the street level.
If I could jump in and just add to that, I agree with everything Katie said. And what she talked about is at a state level, what can be done. Individual organizations, if given the correct incentives, which I think prepayment is, have a remarkable opportunity and commitment. And I think they've got a really, really good track record of focusing on people where they live. The challenges that are faced by individuals vary. They vary both across demographic types and within demographic types. And the key is to identify what is most relevant to help each individual live the healthiest life that she or he can and bring those resources to bear. And it turns out that that's good not only for those individuals in maximizing their health, it's also very, very good from a financial perspective because you mitigate all kinds of downwind clinical problems that cost a lot of money. And so whether it's going into, in the case of my own organization, a huge focus on, for instance, prenatal care, which is going to vary hugely depending upon the type of the population. We have immigrant populations and refugee populations who have very, very different expectations for what constitutes good prenatal care, and being able to meet them where they live and be able to provide the services that will maximize the likelihood that they'll have a healthy infant is enormously beneficial to them, to their baby, and from a financial perspective. I mean, this is one of those wonderful, rare examples. And it's not just that one. It covers people with diabetes. It covers people with asthma. It covers people in unsafe living conditions. It's seniors with homes that pose risks for falls and other things. All of those things, the mitigation tends to both help the people and be less expensive. So that's why I am so convinced that we are going down a path towards prepayment that will yield results in equity as well as in cost and quality savings for the population at large.
If I may, can I just jump in on the equity side? Because I do appreciate you raising that, and I appreciate also the mention earlier today on the vision and culture, kind of strongly emphasizing equity and eradicating disparities. I think in terms of the responsibility, the community partners really are key, and whether that's a shared accountability that's built into a model is something that I think merits further discussion. But I agree with Katie that right now it's really the hospitals that are serving the role as convener and the ones that are quite honestly with recent policies that have been finalized, are on the hook for screening and the referral, from a reporting standpoint on at least the inpatient measures. And so the fact that those are already in place at the hospital level would certainly want any future models to kind of align with the responsibilities that hospitals already will have in terms of screening for social determinants and connecting to community-based organizations and referral sources. The shared accountability may come into play perhaps in terms of data, in terms of kind of how to share data more seamlessly between medical and non-medical providers is kind of an area that's been somewhat sticky so far, and certainly having a better feedback loop between the medical and non-medical would help in terms of tracking outcomes and as part of a value-based model. And I think that's something that to be considered.
Just would quickly add to what my panelists have also already said. I think the way that we are currently doing it, or at least the ACO REACH model is doing it, is to allow for higher spending for certain populations. And the one thing that is unclear is how much additional dollars need to be allocated to addressing sort of health equity concerns. And I think this is an area of experimentation that is needed in trying to figure out what that appropriate level is.
Great. Just one question for Katie. You mentioned you are doing some bundles in the Maryland program. I think you said. I was just curious, are they generally around procedures, clinical conditions, or just wondered what your experience has been in Maryland around the bundles?
Sure. Thank you for that. So we just started in 22, calendar year 22. So we were working to put together what bundle that would be. We have some constraints because of our model. Our physicians aren't able to participate in the national models. Our waivers around accountability and value-based payment is through the hospitals. So we were trying to craft a physician-owned, a physician-directed model program that we could kind of fit under our own. So it took us a while to figure it out, but we started in 2022 with 3 specialty areas, gastroenterology and general surgery, orthopedics and neurosurgery, and cardiology. And so we have episodes, we use the Prometheus episode grouper approach, and we have episodes within those specialty areas. We hope to add additional areas in the future, but for this year, those are the 3 big ones.
Great, thank you. Okay, moving to the next question. So, what do you see as the best options for structuring the payment methodology for population-based models? And you've addressed some of this in some of your answers. But if you could expand on that. And also, what are some strategies and interim steps that can help providers successfully transition to increase financial risk? Alice, I'm going to start with you.
Sure. So, I think there are several steps that need to be taken here to restructure payment methodology that encourages both initial participation and sustained participation. To address, I think, the first issue of just how can we help providers, take on increased risk. A qualitative study from the RAND organization and the American Medical Association found that it's particularly challenging for smaller practices to take on the infrastructure investments that are needed to succeed in these advanced payment models. And so I think something that needs to be done is to have a track that allows for smaller organizations to take on low-risk options that encourage participations. Now, should they want to progress towards larger levels of population-based risk covering total cost of care in the future, they can, but this sort of low-risk option should be made available for them to participate. I think the other sort of really important point here is about benchmarks and how we're benchmarking providers and their ability to sort of save money. There needs to be some on-ramp for new providers to to be willing to join. And I think setting benchmarks based on historical fee-for-service spending, as customarily done, is a really good, helpful starting point. The question is, how do you then take into account incentives to then encourage sort of savings? And something that needs to be done with caution is squeezing budgets over time should be done gradually rather than abruptly. And I have some research with Michael McWilliams that shows that when you change the benchmarks in a large way and you reduce those benchmarks, making it more difficult for, say, accountable care organizations to spend below benchmark, it leads to really large dropout from the program. And unsurprisingly, the people who are dropping out, or the organizations that are dropping out, are the ones who are unable to achieve savings in the prior years. And these are the high spenders that you particularly want to be participating in the program. So I think care needs to be done when trying to incentivize reductions in spending when thinking about that benchmark. And the last point I would say here is just about how benchmark levels should be updated. Currently, what's happening is benchmarks are being updated based on historical spending. And this kind of rebasing based on sort of previous year's performance will penalize providers who have achieved savings in the previous years. In other words, these are the providers who reduce spending will end up with lower budgets in the next year, and that's a perverse incentive. So, I think to summarize, we want to encourage providers who are high spenders to reduce their spending, yes. But their benchmarks cannot be lowered so severely that they find it unappealing to participate to start with. And to increase participation, set benchmarks initially based on fee-for-service spending and then update them based on some administrative growth factor. And this is something that Maryllen's done, which maybe Katie can talk more about. But Maryllen's global budget revenue model does this, sets this sort of budget spending growth rate at the outset of the program at 3.58%. So we have precedents for this kind of model.
Great, thank you. Katie, actually, you're next.
Great, thank you. So I do want to piggyback on something that Alice did mention, because it's one of the things that we've had experience with in terms of the larger organizations are able to absorb risk and take on risk in a way that smaller providers, and if we're talking about physicians and physician practices, smaller practices are not able to. So in order to take on that risk, a provider needs to make sure they know how to use and analyze the data, the patient data that they have. How can they make sure that they're using it, that they understand it, so to the extent that larger organizations have that infrastructure and have more of that ability to risk stratify, to add options. It's, easier to start with the larger organizations and more difficult for the smaller providers. And we've certainly seen that through we have a primary care program that provides non-claims-based payments to primary care providers for advanced primary care. But we also partner for the small primary care providers. We partner them with care transformation organizations to help provide that infrastructure that they'll need to better take care of and manage their patients under a total cost of care model, global budget model. So that's what I would say is, I think the options can be more aggressive for larger organizations, but not, perhaps a little more cautious with smaller provider groups. And then using data, making sure that providers in the program know how to use the data that they have to best manage their patient population.
Great, thanks. Greg?
I'll try and be really brief. Again, I think that terminology is interesting here. We've spent decades talking about prepayment as being risk. And anybody who's lived through the last 3 years as a provider recognizes that fee-for-service is risk too. The number of hospitals that have been dramatically impacted as their volumes went way down and then way up and then way down again. The impact of that is dramatic, and the associated costs are dramatic. And so to imply that that's not a high-risk environment, I think, whether you're a physician or a hospital or a nursing home, is a misstatement. The flip side, of course, is to say that if you have prepayment, you have an opportunity, you have freedom to treat people more effectively and in ways that you may not have otherwise, I think is really, really important to insert into the discussion. We've seen in our communities, we've had broad rural prepayment in a few areas, and the whole community, with the exception of some payers, but we got a lot of payers to work together on that. And we saw whole communities really effectively making themselves healthier at lower cost. And that was again, a triple aim kind of a win. Which I think is really remarkable, would never have been possible in a fee-for-service world. The other thing that I think is really relevant is if you look at the regulations, a dramatic percentage of the regulations that hospitals and physicians have to deal with and are burdensome to them, tremendously burdensome in many cases, are related to fee-for-service payment. On the one hand, all of the details of the whole billing process and collection process is unbelievably complex and expensive to the point where the billing offices associated with providers consumes a shockingly high percentage of their total resources. We all know that. But the other one is to simply look at all of the challenges that are faced in complying with things like fraud and abuse and stark regulations, which, oh, by the way, are simply there to prevent providers from being seduced by the incentive that we gave them in the first place when we paid them fee-for-service. So taking those kind of things and streamlining them has the potential to have huge benefits. And today, organizations and individual physicians who have tried and been deeply embedded in prepayment find it to be dramatically more attractive than the old system, if you will. And yet, as a nation and as policymakers, and we're all guilty, I certainly am, we still refer to it as the one as being a risk situation and the other one not. And I think that mischaracterizes the situation, and language matters. So let me stop there.
Thank you. Maryellen?
Great. Thanks for the question. And I think this question specifically around getting more providers to take on more risk is one that we know, at least in our own discussions with the CMS Innovation Center, is top of mind in terms of the Innovation Center actually looking at how to define the safety net, being a subset of the providers that are not yet participating as fully as they should. And as Alice alluded to, these are providers that often, these high-cost folks we want in value-based care because of the populations that they treat, really can benefit the most from care coordination. So I think number one, in terms of kind of incentivizing participation from a broad number of providers, but also looking particularly at perhaps safety net providers in particular, where today we don't have a codified definition of what we call an essential hospital in terms of policymaking or for public health purposes. And so I think we would advocate for that type of definition as a way to target model development, design and evaluation, implementation as well, and also to just target resources and make sure that we're aligning all of these incentives with the providers that are providing care. And I can go into that into more detail in terms of discussion. I would also say in terms of the fairness of metrics as being a component that would be attractive to providers, particularly talking about essential hospitals and the safety net. Currently, a lot of the metrics that are used, or most of the metrics that are used, do not include risk adjustment for social risk. We have some kind of models in terms of the readmission program looking at dual eligibility and peer grouping, but we really haven't seen that in terms of measure-specific adjustments for accounting for those social risk factors. And yet we know that kind of the lack of risk adjustment for those social determinants or social drivers really has an impact on readmissions rates, the ability to, for example, get follow-up care or have transportation to visits, food insecurity, and the list goes on. So definitely wanting to enhance the social risk adjustment side of these models. And then I would also say, as I kind of alluded to earlier, the upfront funding. I think we're very much supportive, and we're pleased to see that CMS is proposing the advanced payments in terms of the shared savings program. The caveat I think I would say there, and this may go against the panel a little bit, is that I don't believe we want any distinctions between what CMS has defined as low revenue versus high revenue ACOs. That can get into kind of a two-player system in terms of kind of pitting the provider-led ACOs against the hospital-led, which are often those high-revenue folks. And so I think providing that upfront funding to all providers, but again, in particular, the safety net is something that could help incentivize more providers to join in on value-based care. And then finally, I'll just say having a kind of glide path to risk is always appreciated. And we also saw this in terms of recent proposals in the shared savings program. And I think, again, just having that opportunity for the most number of providers to, and not limit it to just small providers, but also those that we know many of our members are on slim to negative margins, and don't have those resources. And so allowing them to stay in the one-sided risk for a little bit longer and gain that experience is also critical. Thanks.
Thank you. Kathleen?
Thank you. I think I can best contribute to this part of our conversation by offering a cautionary tale about providers and financial risk as it relates to patient access to practitioners. With limited exceptions for emergency services, Medicare providers are typically not required to serve patients. In response to current Medicare payment programs, more and more providers are declining to serve high-resource need patients because of negative financial impact. Alternatively, if providers do serve high-resource need patients, those patients may not be given all the healthcare services they need. So how do we know about these access problems? We hear about them from providers and patients, and you may ask, where's the data to support access problems? Unfortunately, no data is collected to measure care that is not provided, including in the current value-based payment programs. It's necessarily more costly to serve a high-resource need patient. As consideration is given to new payment models, I would ask that models properly account for patients who would otherwise be left out of care, because access to health care is a growing problem. A standardized model or models may be needed to accommodate the tens of millions of patients who make up the vast majority of Medicare data aggregators, but consider, would one model allow equal access to health care for all patients, especially patients who are considered high-resource outliers? Or is there no one-size-fits-all model? In various model option deliberations, please consider how patients who are outliers, who are the most vulnerable, highest resource need human beings living with conditions such as paralysis, Parkinson's, multiple sclerosis, ALS, post-stroke, or any number of other longer-term and chronic conditions, be able to access necessary services through the model. Ultimately, if every Medicare patient has equal access to healthcare services as every other Medicare patient, you will have been successful in choosing the correct balance of financial incentives to influence and incentive providers' risk tolerance, with a commitment to serve all patients and achieve appropriate reimbursement. Thank you.
Thank you. Before we move to the next question, I just want to turn to the committee members. Any questions from the committee to our panelists on this specific question? Okay, hearing none. Next question is a theme that has emerged throughout this year is aligning primary care and specialty care. So what are the best financial incentives to encourage better coordination and alignment between primary care and specialty care? We'd like to understand how best to engage specialists. Gregory, I'll start with you.
Thank you. I'd like to piggyback my answer a little bit on that last question, because I think that as we contemplate in a fee-for-service world, the most vulnerable and in many instances the most challenging patients to see, what's the downside to an organization if they don't provide that care? They lose a little bit of fee-for-service. And oh, by the way, then the patient shows up and pays them big fee-for-service when they have a catastrophe that ends up in the emergency room and then the ICU. On the other hand, in a prepaid world, you've got tremendous incentives to focus on the needs of that person before they become a catastrophe. I would argue that the most effective way to ensure that the most vulnerable receive care, the most needy receive care, is through an appropriate prepayment mechanism, which leads us then to the issues of how do we coordinate primary and secondary care. And I think that there are probably three main models that are being contemplated. One of them is the old gatekeeper model. I would argue that that one's remarkably unattractive because it irritates primary care docs, it irritates secondary care docs, and most of all, it irritates beneficiaries. That it doesn't work for anybody. So if I could, I'd sweep that one off the table right away. The second one is the idea of using a combination, and we talked about this back with the first question, of a combination of bundled payment working in secondary care and prepayment, overall prepayment in primary care. At that point, the primary care clinician or primary care team, which I hope is the case, would look at when an appropriate time is to go and bring in a specialist who then has a holistic bundle to try and provide the services effectively and return them to their state of health and well-being in primary care. Of course, you've all mentioned, all of my colleagues have mentioned the huge challenge that we have in defining when a bundle begins and ends. It's incredibly complicated. There are a few things that are fairly straightforward. You can think of a hip replacement or something like that as being relatively easy to put into a bundle. The trick is knowing if the bundle itself is appropriate. As I think it was Alice who mentioned, relatively modest improvements in the cost associated with a bundled payment. Where we've seen something that works far more effectively is where the bundle is for the disease rather than the treatment, because in many instances we've all seen the examples where back surgery was found not to be the appropriate intervention, and avoiding that not only reduced the cost, but it also reduced the likelihood of a bad outcome associated with that invasive procedure. So trying to define what a bundle is, when it's appropriate, those are the huge challenges. Creating integrated teams, you're not going to be surprised based on everything I've said, that integrated teams we think is the far more effective way to do it, where you've got specialists working with primary care physicians to know when an appropriate treatment is required, when it can be avoided by early intervention, and when we can take care of them effectively with the aftercare so that no reoccurrence is likely to happen. And I think this ends up being really important. We've certainly seen it in our organization. When the specialists and the primary care physicians work together as a team, the outcomes are dramatically better. We start to see a reduction in the number of times when specialist care in the traditional sense is incurred because the specialist actually participates early. Mental health integration may be the most frequently discussed example, where having mental health specialists help primary care physicians to make a more effective diagnosis, and in many cases provide direct treatment instantaneously, as opposed to try and bring them to a mental health professional who, oh, by the way, is in short supply, and yes, we can get you in next February. So, there's a whole series of, we think, highly beneficial mechanisms that occur when primary care and secondary care works very, very much hand in glove. And that's hard to do in a fee-for-service world, very, very easy to do in a prepaid world.
Did you, go ahead, Angela.
Thank you. This question is for Greg. So how many independent physicians are in your broader network, and how do you engage those primary care and specialists to participate in the models you're describing?
Yeah, it's a great question. So many people ask us, how are you different than, say, a Kaiser Permanente? And we are just about 50% of our clinicians, both primary and secondary care, are employed, and about 50% are not employed by us and are affiliated. And what we have essentially done is to say, we'd love to have you, the employment decision that you make is based on the way that you want to manage your finances and run your office. That's great. We're delighted either way. Some people love to be an entrepreneur. Some people hate the idea, and great, make that decision. But what is not negotiable is whether you're going to be a team player. And by that, we mean you need to engage in the rules of when you work with your colleagues, whether they're another independent physician or one of our employed physicians. You will work with the tools that are maximizing value to your patients. So, for instance, you will share data with all of your physician colleagues that care for that patient, as they will with you. And so there are a series of things that don't require employment in order to be engaged as a team member. So we expect, it's part of the deal, if you want to provide care with our team and to our beneficiaries, that you will be a team member. It doesn't require employment, but it absolutely requires coordination. It requires collegiality, and it absolutely requires sharing of information and applying best practices when they're known.
Great, thanks. Maryellen, I'll turn to you next.
Sure, thanks. And agree wholeheartedly with Greg in terms of integration being key. I think specialists are obviously key partners in terms of delivering value-based care, but really need to have the proper staff integration as well as training in terms of actually increasing efficiency and lowering costs. Along with that, I think a lot of success in terms of that integration relies, and Greg noted this as well, in terms of effective communication, having an integrated medical record, as well as having a single shared treatment plan in terms of having everyone on the same page. Also, speaking of data, specifically transparently sharing data, I think that's also key in terms of the specialist side. Kind of without data, I think specialists often have no idea where or how their care actually stacks up, and if there are potentially efficiencies that can be incorporated into their outcomes or their care plans to provide better outcomes at lower costs. And so sharing that data with specialists, I think, is a way to attract them to this type of integration and have them have a little buy-in in terms of their role. I think an example, and I think Greg alluded to this as well in terms of mental health and behavioral health, is a prime example in terms of where integration has worked really well. And that's because, as many of our hospitals deal with patients that suffer from behavioral health issues, they often find that patients are seeking treatment and kind of episodic care from the ED, which contributes to rising healthcare costs, readmission rates, and overall just fragmented care. And so we've all seen our members integrate behavioral health with primary care as a solution to disparities in behavioral health treatment, while also addressing the interconnectedness that we know is between physical and behavioral health. We also have heard from folks about the use of e-consults as an effective mechanism between primary care and specialty, and I believe that was raised earlier today, so I won't go into that in too much detail, but definitely support that in terms of having timely and efficient care and having that loop between primary care and specialty care. I'll also just note in terms of some of the specialties that have thrived, obviously orthopedics comes to mind, probably because of the comprehensive joint replacement model that exists. And so definitely noteworthy in terms of their expanding participation into bundle payment arrangements. However, a lot of the specialty value-based care programs are really focused on again, those episodes of care, like a hip and knee surgery. And so I think if we're looking for that population-based model, we need to get, the other specialties involved, whether that's directly or if it's that the primary care still serves as the quarterback, but it's improving the integration, then that's an area that should be examined. Thanks.
Great, thank you. Alice?
Sure. So, I think I agree with a lot of what's been said. What's interesting to me is Greg mentioned this. It seems like a culture of collegiality, and I think, short of having people buy into that culture, which I agree is very important, there is also just this reality that as the fee-for-service payment model diverges in its sort of financial incentives from advanced payment models, specialists will naturally also be inclined to participate and to buy into that type of culture. Something to note is that, CMS projections suggest that the fee-for-service payments for Medicare are going to rise at a rate that's approximately 0.7% below the rate of inflation through 2030. So the margins for fee-for-service are starting to fall in terms of real dollar values, and I think this is where specialists can realize that making more money by being an efficient provider within an advanced payment model like an ACO can be better or more lucrative than being a less efficient sort of non-ACO provider just accepting sort of fee-for-service. And the last thing I would mention here is, as many of my fellow panelists have already talked about, management teams or care teams. What I want to add here is just this piece of a management team. I think management teams should reflect the views of both primary care physicians and specialists. Physician leadership is likely to have a very important implication for the evolution of sort of strategic design, and survey data has shown that specialists are less likely to perceive that joining an advanced payment model has changed how they practice medicine, has affected their compensation. There's some qualitative studies out there showing that sort of surgery was not part of an ACO strategic visions, at least in the early days. So I think including specialists in sort of this discussion of strategic vision and leadership will also be sort of an important component here.
Great, thank you. Kathleen?
Thank you. I'm going to pick up on what everyone else has already talked about from a patient perspective. Joint coordination should occur between primary care, specialty care, as well as patients to initiate, adjust, and successfully make progress to efficiently and effectively achieve patients' stated treatment outcome goals. So how do we do this? Some patients will have realistic goals to achieve a higher level of function. Some will have goals to return to previous level of function. Some will seek to maintain their current function, while others will strive to slow the loss of function due to a necessarily deteriorating condition. So while practitioners' skills and case management processes may not differ from one patient to the next, providers' joint approach to each patient's health care should respect and adapt to each patient's individual treatment goals. Collectively agreeing on and creating a strategy to measure goal progress as a joint healthcare team will necessarily better coordinate and align primary care, specialty care, and the patient. By managing cases this way, financial incentives for practitioners may, for example, include shared payment tied to each provider's percentage of total time dedicated to a patient, with additional joint incentive provider payment for working together to successfully achieve patients' goals. Thank you.
Thank you. I'm going to open it up to the committee for questions. I'm happy to start off. Greg, you've referenced a few times the integrated care teams. And I just wondered if you could describe those in terms of who's on those teams, and do they vary based on the clinical conditions of the patients? And then finally, in terms of accountability for quality and cost within this sort of integrated team structure, is it who's accountable for ultimately for those measures?
Yeah, great questions. The integrated care teams are very much fluid, and they tend to be built around either a specific patient need. That happens when patients have dramatic needs, when somebody develops cancer and there's a fairly significant kind of need that's going to be multidisciplinary. It also tends to be built around general needs. A number of folks mentioned mental health integration. We started to do that about 25 years ago, and that was built around the obvious need that primary care physicians had to understand more effectively the reasons that some people were requiring care more frequently than others when they appeared to have a very similar underlying condition, and it became more apparent that there was a behavioral health component to that. And so being able to identify, treat, and know when appropriate referral was necessary was part of the deal. And so that was a broad need that was apparent. And so the organization undertook that with everybody's enthusiastic engagement because the need was so obvious. The ones where the need may not be as obvious until somebody brings it up is, and this is a real example in joint replacement, where a number of the surgeons said, we spend an awful lot of time talking to people and discouraging them from getting what they don't come in saying, I've got knee pain. They come in saying, I need my knee replaced because my next door neighbor did. Mm-hmm. And so coming up with an integrated approach that helped to get somebody who was significantly less expensive than an orthopedic surgeon to have the discussion with folks and say, let's talk about what your knee pain is and what the appropriate steps are to try and get an improvement there. And interestingly enough, pushed by the surgeons who in a fee-for-service world would have said, keep your hands off my potential patient. And so that one was one that came up and is now loved by the surgeons who spend less of their time in offices doing things that they don't think is the highest and best use of their training. So it's and then you asked, so where's the accountability? For us, the accountability tends to be at the organizational level. And so through KPIs and other things, we track that as best we can. And I will tell you, absolutely, our metrics are imperfect, but they're better than what we've had in the past, and they're hopefully getting better every year, so that people can look at that and say, are we doing everything that's beneficial to people? Are we avoiding doing things that are unnecessary? And are we keeping people happy and keeping them as healthy in their own minds as they expect to be? I really, really loved what Kathy talked about in people's expectations of what their health should be doing is going to vary from person to person. Being able to meet those expectations and help them on their journey, we think, is really important. So that's one of the important things we track and are in our KPIs that are shared with everybody.
Thank you. My other question is really for all the panelists. Several of you have talked about data in various contexts, including engaging specialists. And I'm just curious that, as a cardiologist, I speak to a lot of cardiologists, and they complain the data they get is not timely, it's not actionable, and I'm curious how you've been able to address some of those challenges around getting data, either to the specialists or just in general to the providers.
I apologize. I shouldn't jump right back in after answering the last question, but just let me say again, provider organizations are in dramatically better position than insurance organizations to do that. We have, if you did a cardiology procedure yesterday, we know about it today, and we can coordinate and report on that. The insurer will find it out after a bill has come, and they have adjudicated it, and they put it into their database, and with luck, 30, 60, 90 or more days from now, you may get information back that said, we're kind of surprised you did this procedure. How come you did it?
Agree.
So if I can jump in also on that question, I think data, understanding data around your patients is really important to making sure you're successful as a provider in reducing unnecessary costs and improving quality and outcomes. In Maryland, like many other states, we have a health information exchange, a common HIE platform that all of our hospitals are connected to. And we've also done a big push to get ambulatory care providers also connected. So that will provide real-time alerts for when a patient who's attributed to you, who you have a clinical relationship with, you'll get an alert if they go to the emergency department, if they have an admission to the hospital, if they have a procedure. And so that real-time data allows multiple providers across the spectrum to connect and see what their patient is doing in different areas. It also has an option for care management and care alerts. So the providers can put in, if there is a point of contact for a care manager for a particular patient, that person can be, that person's contact information can be included, so that if they go to the emergency department in the CRISP HIE record, you'll see what that patient's care management team looks like, if there's a care alert, et cetera. So I think having data that multiple providers can access and learn from for their particular patients is extremely important in terms of coordinating across providers. And then also on that HIE, there's also a prescription drug record keeping also, so physicians can know what the prescriptions that are prescribed to that patient.
And Paul, I'll just echo and sympathize with the lack of data is not there on the. Super helpful in terms of workflow and shared care plan. There's that other side of the claims-based data that we know from providers. It's just there's a data lag, especially kind of quality metrics can be 2 or 3 years, of a data lag that we're looking at. So it's not a great real-time perspective in terms of those metrics. And so that's certainly, I think, a challenge, and wanting to get more prospective data and real-time data to providers is key. The other thing I just wanted to mention in terms of the accountability side of your question, in speaking to hospitals, there is this notion of, and again, kind of that e-consult model, that wanting to get the specialist involved, but there's also a voicing of being kind of housed in the primary care is a positive thing in terms of continuity of care for patients and keeping them connected to a system and a provider. And so wanting to have the specialists come in, but then also kind of leaving it in the provider side. And quite honestly, that also probably helps on the social determinant side of things, because I think we know primary care, they're not so far along, but they're, I believe, a little further along than specialists in terms of developing the infrastructure to address both the clinical and social needs of patients. So something to consider on the accountability side.
Great, thank you. Larry.
Great session. I'm learning a lot from all of you. My question is going to go out to whoever feels comfortable addressing it. We've heard a lot from each of you about the comprehensive joint replacement model, bundled payment for procedure type services. What type of team-based reimbursement models have you developed for chronic disease management, patients with either single or multiple chronic diseases? How do you distribute payments and incentivize across the primary specialty interface there?
Okay, I'll jump into the silence by saying I don't think it works. I think that's where in fact is Michael Porter and Bob Kaplan wrote a Harvard Business Review article a long time ago, decade ago, and a colleague and I wrote a counterpoint. His was How to Pay for Health Care, and it was about bundled payments. Ours was called The Case for Capitation. You can guess where it came from. And our point was, for all of those things, the bundle that you're looking at is care for a person over a period of time. And at the longest period of time you can define as effective, because by definition, these diseases are not going away. And if not cared for, they're going to get worse. If cared for effectively, they may not. They may actually improve. So in our view, my view certainly, that's the key there, is to say that's not a bundle. That's the whole person care. And oh, by the way, the deviations they have in their care pathway, they may end up developing some other issue that's not specifically related to their congestive heart failure or their, fill in the blank, but it's going to be dramatically impacted by that. And to care for them as though they were a bunch of individual diagnoses is not going to be effective. It's not going to be healthy, and it's not going to be satisfying. So we need to look at that person from a whole perspective, which is why I think we have to pay them from a whole perspective.
Any other comments? If not, Bruce?
Is there time?
Yeah, always time for your questions.
Earlier today in another panel, we had a robust discussion of the role of fee-for-service in value-based care going forward. Paul, I'll start with you, because I think at one point you said if the organization has the proper incentives, you don't think they necessarily have to devolve down to the individual practitioner. And at the time you said that, I wondered if that meant you were indifferent about whether that practitioner was paid fee for service or salary or through some other methodology. So my question for all of you is, do you think that going forward we should be trying to phase out fee-for-service compensation, or is there an ongoing role, or at least a necessary role, for fee-for-service under value-based payment systems?
So, Greg, I'll let you start, and then I saw Alice leaning in. So,
okay, I'll try and make this really quick, because I know we're getting short on time.
That's okay. We can go over a few minutes.
My prejudice is that anytime we're unsure whether the procedure may end up becoming unnecessary but done for financial reasons, fee-for-service is perverse. And most of the time in today's world, unfortunately, I believe that to be the case. So we're moving in our organization wherever we possibly can. This is one advantage to having employed physicians is we can move to salaries. We haven't figured out how to do a salary for people who don't work for our organization directly. We think that that tends to be a more effective way. The however is with appropriate metrics, KPIs, and other things that are shared, you can overcome perverse payment mechanisms. I just hate the fact, though, that we have to overcome something perverse. The payment mechanism ought to reinforce doing the right thing, not be pushing you in the wrong direction. So in my view, I'd love to see fee-for-service history.
So I probably have a more mixed or nuanced perspective on this. I think everyone, or it's not controversial to say that fee-for-service is inefficient and creates perverse incentives, as Greg has sort of pointed out, and others on the panel as well. We know we've seen other countries do this where there's fee-for-service with global caps on what one can spend. And that limits some of the incentives of fee-for-service of I'm just going to bill and spend. And there are mechanisms that one can design that we, I think, are in the process of doing in terms of changing the fee-for-service rates into something that look more capitated or some combination of capitated with fee-for-service, which can be changed with things like bonus payments or penalties. And it shifts the incentives that are inherently there with a fee-for-service of let's just bill and spend. And so in that sense, I think one could devise a system that reduces the inherent inefficiencies with fee-for-service without completely abolishing it. And it does have, I think, the benefit of just knowing how much you actually are saving and spending when you still have some sort of fee-for-service benchmark. But I absolutely agree with some of the things like it just doesn't make sense to continue adding in more fees and services for new things, including things like telehealth and other new technologies. Yeah.
Okay, well, thank you so much. On behalf of the committee and our audience, I want to thank all of our panelists for their insights today. We're very grateful that you've been generous in sharing your expertise. So at this time, we have a break until 3:15 Eastern Time. We will reflect on the day and discuss some potential comments for the report to the Secretary. Thank you very much.
Produced by the U.S. Department of Health and Human Services.